Well, good afternoon, ladies and gentlemen, and a warm welcome from a magnificent Cape Town. I have with me Professor Steve Jeffrey. And Steve, it's wonderful to have you over here this
I'm doing
afternoon.
well. You too. Wonderful to be here and have you here too.
Thank you, Steve. And my name is Peter de Jong. And we also have um, a stellar lineup this afternoon. We have Sangesu Machacha from Aspen, and he's going to say a few words. Then we're going to have Celeste von Drünick, and she's going to say a few words as well. And I'm going to introduce you to Celeste because I think it's her first time here, Steve. Is that right?
Yeah, I think
That's
so.
it.
Yeah.
And we're going to be hearing about HPV screening, all you want to know and all you were afraid to ask. But don't be afraid to ask because Celeste is an expert in oncology. She qualified at the University of the Western Cape as a subspecialist in gynecology. And sorry, I'm
Being
not
rude
that.
now, eh?
I'm not being rude. You mean Tygerberg Hospital, University of Tygerberg. And she's going to be talking to us about HPV screening. But before we get to Celeste, we're going to get to Sangeso. Sangeso, thank you very much indeed on behalf of the Pelvic Floor Foundation for Aspen sponsoring this afternoon's webinar. Would you like to
Yeah.
say a few things, Sangeso?
Yes, definitely. Thanks, Dr. Diong. Good evening, everybody. As Dr. Diong has said, my name is Songezo Mchacha. I'm the brand manager for the Aspen GSK vaccines, and I just would like to give a warm welcome to all the healthcare practitioners that have joined tonight in this webinar for health, female health, as well as HPV prevention. So HPV remains one of the most common viral infections globally, as we may all know. And through education and initiatives like these, we're able to reduce this burden of disease. And as Aspen, we remain committed to supporting initiatives like these and to further just reduce the burden of disease and improve public health outcomes. Okay. At Aspen, we're responsible for Cervarix and GSK. We're responsible for Cervarix, which is a bivalent HPV vaccine for HPV 16 and 18. And it further provides cross protection against your HPV 31, 33, 35, 52, 58, and 45. Altogether, 8 strains protected altogether. And thank you once again. I hope this is impactful to you, and I hope it adds value to your day-to-day practice. Back to you, Dr. Dion.
Thank you very much indeed, Sangeso. And it's wonderful that Aspen is able to assist with this very important drive and educational opportunity. So then we
Yeah.
move straight on to Celeste. Celeste von Drünick, as I said, is a subspecialist gynecologist oncologist. She works at the Vincent Pallotti Hospital. And it's wonderful to have you here. You qualified at the University of Stellenbosch. And for that reason, I'm sure you're ideally placed to help us with HPV screening and prevention this afternoon. Celeste, over to you.
Thank you very much. Good afternoon, everyone. I'm just going to share my screen. Let's start. So you guys can see
We
my...
can?
Okay, great. So everything hopefully you wanted to know about HPV, hopefully I'll cover. Just to say that I don't have any disclosures. Nobody's paying me anything to say anything about any vaccines.
Would be
Uh,
nice if they were.
Yes, it would be nice. Because I really believe in vaccines, so we're going to talk about that. So what is HPV? So it's a DNA virus. We all know it's a virus. And the life cycle is completely dependent on the epithelium um, of the lower genital female genital tract. Sorry, I just want to quickly advance. For some reason, it does that. There we go. So we know it causes cutaneous infections depending on the type or mucosal infections. And it's a very clever virus because it doesn't cause any cell death or viremia. I just want to get a pointer here so that I can also laser a pointer. There we go. And it actually engulfs itself into the cell in the basal part of the mucosa. And then as the cells then shed later on as they get older, the virus actually exits and then patients can reinfect themselves or there can be reactivation. Let me quickly just move one more thing here. Sorry, I can't see my slides properly. I just want to move there we go. All right, so, no, it doesn't want to advance. Let's see. There we go. So we've got so many types of HPV, and they're all sort of grouped. And a lot of you have probably seen, if you do HPV testing, you get different types and then different pools that we pool them in. It's important when we get to vaccine protection, and to know obviously which ones are the most carcinogenic. So those ones who cause the most cancers and problems that we are faced with. We all know, that we get the squamous lesions on the cervix, especially by 16, and then the other types, 18, 31, 52. You also get other types of cancers, and incidentally, those other types of cancer are actually on the rise. Anal cancers, penile cancers in the world. Actually, we're not doing very well in preventing those, although overall the incidence is very rare. They're also actually on the rise. So what about HPV? Well, it is a sexually transmitted disease, and men and women are both involved, obviously, in the epidemiological chain of infection. You can be both an asymptomatic carrier, a transmitter, and a victim of infection at the same time. And I always say this, I probably have said this a million times, that more than 90% of sexually active men, I don't know why the numbers differ, but this is the proposed number or percentages, and more than 80% of women in their lifetime will be infected with HPV, even if they only have sex with one partner. So yes, that can happen. If that partner had sex with one other partner that had HPV. And most patients are asymptomatic. And then another important thing to note is up to 90% of patients clear the infection within 24 months. So don't be too despondent if it's not gone after 12 months. You can give it another 12 months, depending on the type and the patient's history, and we'll get into that now. So what about...
Celeste,
Yes.
are you going to tell us how you clear a virus? You're going to
No,
come into...
Yeah, so I always get the question by patients, what can I do to make this virus clear quicker?
Right.
Okay,
Yeah,
so
that's the question.
yes, yeah. So I'll tell you about vaccination and where that comes into play, but the vaccine directly does not clear a current infection. That we do not have evidence of. We'll get to when we've treated patients, or when we are going to treat patients for a CIN lesion. Yes, then it can make a difference. But you can tell the patient basically there's nothing they can do. I always say, obviously, live a lifestyle. And the one thing they shouldn't do is smoke, and we think vape as well, because that does alter your immunity and does decrease the clearance of HPV. So that's the only thing they can really do.
No smoking.
So as you can see here, with the natural history of HPV, okay, they decided on this graph to start at 15 years of age, but this is just a model. A lot of people actually get HPV on their cervixes that are infected. Most clear it, and as time then progresses, they can develop a precancer. Obviously, not everyone, and then eventually some of them, a lower percentage, can develop a cancer, depending on the persistence and the type. So, if I can go to my next slide. I don't know why I'm not advancing. Let me just say next. Okay, so what happens is you get an infection, you're exposed to it, the virus can persist, it can progress into a precancerous lesion, and then if sometimes, not always, there can be invasion. So there are a few risk factors for that, but as I said to you now, most of the times people clear the virus within 1 to 2 years, and about 15%, 10 to 15% of patients, we don't know why, we don't know how. Yes, in immunocompromised patients, they don't clear it as well, for whatever reason they might be immunocompromised. Important thing to also note that even if you have a precancerous lesion, there are some precancerous CIN2 lesions that can regress. Obviously, we're not going to take the chance because it is considered a precancer, but it can, technically it can. We just don't always want to wait for the cancer before we prevent the cancer. So it's important just to note that this can happen, and it can go back and forth for many years with some patients. And the median time to a CIN3 lesion from infection, usually this is now with HPV 16, is about 5 years. And then, of course, we have risk factors for invasion of cancer, where it depends on the type. If a patient is immunosuppressed, smoking, we think there might be something with HLA in the immunity and genetics. Of course, this is just related to COC use and the multiparity to sexual behavior, and not really anything else. Or directly because of COC use. So I've gotten that answer also before.
So
Yes.
yeah, because what we're going to do is tomorrow I'm going to get emails saying, does COC
No. No. So it's related to early COC use because you've been early, you needed, COC use early in your life because you had multiple sexual partners. So it's related to the sexual behavior around it. So it's a known risk factor, but it's because of the sexual behavior. Definitely not. The COC does not cause or, increases the risk of invasion. Definitely not.
So did you say, just to there, did you say
Yes.
the mean or the median time for invasion from infection with HPV 16 is 5 years? Did you say that?
To a sensory, yeah. But I mean, it depends on the patient. So a patient with HIV positive, we see, and we'll see in my later slides, they can progress to a sensory much quicker, a year to 3 years, because their immunity is not intact. This is obviously a graph, and that's just the median. And it can be 8 years, it can be 10 years, it can be 20 years for some patients. And we don't always know, when the patient got the HPV. It's very difficult to pinpoint usually when the HPV infection was contracted. Okay, so this is important. The WHO has brought out this subtyping and of the carcinogenicity of HPV types. And if you can see here that HPV 16, really, I'm the most scared of HPV 16. It's very prevalent in cervical cancer. And so if you have it, your odds ratio goes up significantly to develop cancer. Then we go to 1845, still in group 1, which is still considered the high risk. Then we get the other high risk ones, that goes down with the numbers. And then we get these green ones that make a lot of people nervous, and it's good that we're flagging them and seeing them, but sometimes they can confuse us, depending on whatever you use after that to triage, and I'll get into that now. But it's good to know that we can subtype because it does help us, and I'll show you the algorithms later. I'm not going to bore you with algorithms, but how it actually comes into play, because we know, because of this, we know we can triage patients and manage them better in their surveillance pathway. So in South Africa, and this is now overall in South Africa, not in private care, but overall it's really mostly HPV 16, and then we see the other types, that also usually causes the cancer. 35 plays a big role, more than any, and more in sub-Saharan Africa. So it's still in the other high-risk group, in the orange group, which is important. And then obviously you get the 45, and we also 18 and 33. This is just to show that we're really not where we want to be in South Africa. I just want to move this. The ranking of cervical cancer is #1 in the young women in South Africa, and it's the #1 killer of all cancers in South Africa. Not breast cancer, but cervical cancer kills women in South Africa. Okay, so then the WHO has brought out these goals for 2030. It's the 90-70-90 goals that they've brought out, and it's really to prevent cervical cancer as much as we can. So the first pillar is the 90% or the 90 pillar, and that's our primary prevention pillar, HPV vaccination. And we want 90% of women in your country or population to be vaccinated by the age of 15. And I'll get into more details about later and catch-up vaccination, but it's important that we try and vaccinate everyone and all girls, at least all girls. Then 70% of women needs to be screened by a high-performance test, at least by age 35 and 45. So WHO is aiming for just twice at least if we can. Obviously, we're going to do that more, and I'll tell you how. But that's how we're going to prevent it in a secondary level. And then tertiary level would be then to treat if there are any abnormalities, precancers or cancers. That's very important. So let's go yes.
So can you just tell me what is magic about 90%? Where does that 90% come from?
There's epidemiological studies where they decided, they modeled that if we get almost 85 to 90% coverage, we'll get herd immunity. So it's that's why they've decided. They've obviously looked with
It's a mathematical model.
It's a model that they use, and they decided they want the population to, we're aiming for that. Yeah. But we're not doing bad in South Africa. I don't know the latest number or percentage. It depends on the area, obviously, also in South Africa. But in places like Australia, they're quite close. They're like 88%, and it's doing the trick. We can see the numbers of cervical cancer really, really falling there. And I'll show you later a bit of few numbers there. So what is HPV? What is the HPV vaccine? So a lot of people are, this is especially for the patient that's scared of vaccines or the anti-vaxxers. What is it? It's virus-like particles. So it's not a live virus. There's no genetic material of the virus in the vaccine. It's completely safe. It cannot replicate. And it's just because it looks like it. And the virus-like particles helps you to build this immune response that you then get the effect of enhanced clearance. Okay, so does it work is the next question. Yes. So if you get the vaccine, and I'll tell you about how many doses soon. But yes, male and females usually get seroconversion. It's very effective in preventing CIN lesions. So this has actually changed now, and I should have edited this. So the bivalent vaccine or Cevarix actually has a 97, this should be 97% efficacy in preventing SIN2 plus lesions. So it's a very effective vaccine in preventing precancers. It prevents VIN and vaginal 2 to 3 lesions. It prevents anal neoplasias, and it also, does prevent anogenital warts when it's included in that schedule or in the type of vaccine that you're using. So what do we have? We've got the bivalent, the quadrivalent, and the nonavalent. These are the trade names. And you also get cross protection, which is very important to note. Because of that family tree and that beautiful tree that I showed you there, it's actually important to understand that even though this only protects against, or is, no, let me say, it's just made to protect against 16 and 18. There's lots of cross protection because of the family tree of HPV. So 31, 33, 45, 52, 55 as well. This is the quadrivalent one. It also has a little bit of cross protection for more. And then, of course, this one who has direct protection against other strands. All right. So does not want to advance. Is it a safe vaccine? It's so safe. I mean, they think that's we're close to 1 billion has been distributed. There's been no issues afterwards. I mean, you get mild reactions, pain at the injection site, a bit of, low-grade fever, maybe, arthralgia, nausea. There was at some stage social media issue about it's causing autoimmune conditions, which it definitely does not do. They've actually studied that. It does not cause infertility. So, there was also a big social media thing about that. It's very safe for young patients, and they've actually studied it up from 6 years of age. We give it from 9, but it's very, very safe, and it works. In pregnancy, it's not recommended to give it, but just FYI, if you've given it inadvertently, in week 3 of the early pregnancy and now, or 6 or whatever, and then the patient found out that she's pregnant, it's not an indication for termination of pregnancy. You're just going to go through all your normal surveillance and checkups as you would, normally. And in breastfeeding, it's even safe. So how should it be given? Well, that's the dose. It should be given as soon as it's out of the fridge. And then the next question is always, what is the number of doses and should you get a booster? So the answer to the booster is no. Even if you've had one and you were young, usually it's not necessary to get a booster. What does the WHO say? So they say, I just want to, sorry, give me 1 second. My screen is freezing here. Excuse me. Come on. So young females, you can use 1 or 2 doses. So it's actually changing now. And there's a very good study in the I think it's the New England Journal of Medicine that has shown that you actually only need 1 dose for patients under 20. So that's why the WHO says, well, we're actually making it for everybody under 20, 1 dose is fine. Above 20 years of age, you need your immunity doesn't respond as much. And so you definitely need 2 doses, but at least 6 to 12 months apart. HIV positive or women living with HIV, you do need 2 doses. We're not really sure about 1 yet, but definitely 2, and you can give 3. And in males, if you can and you can afford it, definitely it's advised. And if they're above 20, also the same as for females, 2 doses, at least 6 months apart. So the next question usually is, but what about a current CIN lesion, previous intercourse, or this current wart or an abnormal PAP? Well, it's not a contraindication, and actually it's advised, and I'll tell you why in the next slide as well. So in South Africa, as a reminder, in grade 4 in public schools, So 9-year-olds do get the bivalent vaccination in 2 doses, and they've actually changed that now with the new evidence that you only need 1 dose. So hopefully we can use the other dose for males soon. I don't know, but I'm hoping. And just to remember that if you're seeing the private school girl in front of you, they are not being vaccinated. And if they didn't go to a private clinic for their vaccinations as a baby, later on, they are not vaccinated. And I see that often, that they are actually being missed because they're not in the public schools. So remember about them. Oh, this is just that was the New England Journal of Medicine, where they actually say 1 dose is not inferior in HIV negative patients. HIV positive patients, we don't really have data about 1 dose. They are busy studying it, so we wanted to give 2 or 3 at least doses. So the question was always, if somebody's HIV positive, is it safe to give the vaccine? And the answer is yes, you need to give it as soon as possible. There's a very large trials, randomized controlled trials called the Doris trial that showed it's safe. It does not affect, their longevity, their CD4 count, their opportunistic infections, and they definitely need 2 to 3 doses. Women living with HIV have really struggled to clear HPV. So they've got a high incidence prevalence, higher viral load of HPV, more multiple types, more 16, 18, the high risk types. They've got more SYN lesions and VIN lesions, a shorter time to those lesions and to invasive cancer. So really, we do need to remember about them and vaccinate them. So
Celeste,
yes.
sorry to bother.
Yes.
Marcus Fasson has actually said something on the chat about the Deputy Minister of Health announcing in 2025 that HPV vaccination will be expanded to private schools.
Oh, okay. Actually, I
yeah.
didn't even know. I didn't
Yeah.
know that. Thank you for that. Yeah, that's great news. I'm glad to hear that because I've seen a lot of that being missed in my current, almost 2 years practice now in private care.
There's something
Okay.
happening at private school level to try and capture those girls, because obviously, I think private schooling is getting more and more widespread. You've got Kuros
Yes.
and all these
Yes.
schools. You can imagine trying to get all the herd immunity with all these private school girls not getting vaccinated. And
No,
even if
100%.
out of
Yes.
mind, girls are maybe in high school already not getting vaccinated. So it's obviously quite a big issue.
No, for sure. And yeah, and so these patients can definitely afford it usually. I mean, I shouldn't stereotype, but usually they can because they're not going to get it for free. But luckily now they are, since the end of last year. So that's great news. I just hope that they get to the schools. The unfortunate thing about the vaccination is it's an opt-in thing where the parents has to sign consent. So that always becomes a difficult thing if the child forgets the paper in the suitcase or whatever in the bag, and they don't let the parents sign. But yeah, as long as we can all raise awareness, and if you see the teenager in front of you, ask the question. It's never too late. Just vaccinate them.
Celeste,
Yes.
sorry, are you going to be speaking about anti-vaxxers or not yet?
I've tried to touch on it. Did you have any specific question?
No, just saying
about
a
it?
terrible case, talking about vaccine and opting out and opting in. I have a case now of a young girl of 22 whose mother is an anti-vaxxer. She was not vaccinated, the daughter, and the daughter is now 22 years of age with a high cell of the cervix.
No.
So to me, that's a tragic case
No,
of
it is. It's completely tragic, especially at that age. Yeah. As I said to you, I'm trying to convince the anti-vaxxers what they want to believe. I can only give them the information, but it's completely safe, and that's why I gave you all of those facts before, all of those bullet points, so that you really can say to them, it does not cause any autoimmune issues, infertility. It does not mean that your daughter is going to be sexually promiscuous. Please just vaccinate them because they can have, and I see it, I've seen it, and I'm young. I've seen it that young in my career that the girls come to me or the young women come to me and they've only had intercourse with one person and they, and they have HPV 16 and now it's 5 years later and they have they need a LETS. So it does happen. It does not mean that your child will be promiscuous.
Yep.
And you need to try and portray that just carry that over to the patient or the mom in front of you more than anything. So this is just to say, this is what I've actually said already. about who should we vaccinate. The question was also, should we just target high risk groups? There's been a big debate about that, but it's very difficult to just decide in front of you, face value, who do you think you should vaccinate? So it's more cost effective to just say we're going to vaccinate everyone. It actually shows in the modeling studies that it's better and it's just as cost effective versus just vaccinating a few people, but then getting more precancers is in any way going to cost, the country or your health sector more money. And so also, there's a lot of discrimination and stigma around if you're now going to decide. So everybody through the bank should just get the vaccine. So I just want to touch on this again and the reasoning behind why we should vaccinate HPV positive, even if there's current infection. Not because we think it's going to clear the current HPV infection, or if there's anything else, that points to previous sexual intercourse or HPV infection. So an existing HPV infection does not mean that you've been infected already with all types. You might have just been exposed to one type. It also doesn't mean immunity against reinfection. So your own immune response is not a very good immune response. And if you were somebody that was not going to clear the infection of, let's say, 16, but now you've been exposed to 18. Now you're already not clearing 18. Now you do get exposed to it, you eventually clear it, but now your own your immunity response is not as good as the vaccine. It actually makes a big difference just to get the vaccine. It's not good enough. Natural infection, basically. And so that protects you from future disease. So I just say it's still beneficial because it can protect against other strains, future acquisition, reinfection, that's the other thing. And then the other thing that I've touched on is recurrent dysplasia after treatment. So this is actually a meta-analysis. It's retrospective data, but it shows 50 to 65% reduction in recurrent CIN2 lesions in somebody that has been vaccinated after treatment. Treatment meaning a LEAP or a LETS, where you actually had to treat the cervix for a CIN2 plus lesion. So when you are doing the LETS, you're seeing the CIN2 or 3, you're doing the LETS, vaccinate them at the same time. Ask the question first, have you been vaccinated? If they're not sure, give them one dose. It does make a difference. That is what we definitely see.
And is this covered by medical aid? Say they're inpatients. Now, you've been in private for 2 years. Can you write up, administer the vaccine, whichever one?
I've actually never done it that way. I actually don't know. I usually just give it as an outpatient script, but it's actually not about, I must actually find out about that. I don't know if
while they're in hospital, maybe medical aid will cover.
Yeah, because, like Discovery, you get so many points just for going for a pap smear. So really, I would think that they would. I've never actually thought about this or found out. Yeah.
I don't know if it's dispensed. I can find out, but someone's bound to know and is bound to tell us just now.
Yeah, they must please tell us if someone in the audience knows, please. It's a very good point. So when you're a patient for the theater, let's write up the vaccine if you can, and it's a good reminder just to give it.
We'll hear.
All right. So I have to say something about screening as well. I'm not going to go into it's a lot, to talk about prevention, primary prevention, HPV vaccination, and screening. But I'll just touch on a few things here. And more common questions that I sometimes get or that we get as gynae oncologists. So there are new guidelines from the WHO that was already published 2021, so a while ago, right? It's not that new. Screening is we're trying to screen 70% of women with a high performance test. That's why they put that in there, at least twice in their lifetime. So does the WHO say? They say your next screening test or your primary screening test should be HPV. Okay. If you want to do cytology as well, that you can decide. But really, we should be testing with HPV. I'm going to give you more stats in the next slide as to why. But it's very important that we all make the move, even though we don't want to have the conversation of why we have it, what is it? It's an STI. Yes, it is. Really, it prevents more cancer if we test with HPV than with cytology. So It depends. They differentiate between the general population and women living with HIV, and saying how to screen. So screen and treat is that immediate reflex thing where you have in more in a resource limited area where you don't have good follow up or maybe skills or whatever to do a colposcopy is not available. Then you can do it for some of the high risk types, and I'll show you that now. Or you can screen, triage, and treat. For women living with HIV, it is important to screen, triage, and treat because a lot of them will have a positive HPV test, and you don't want to do letters on all of them, but you need to triage them carefully. And then they say who should do the screening? Well, you self screening is also really coming to the forefront now and helping a lot of women that have vaginismus, or you really don't want to go for the pap smear for whatever reason. It's even acceptable to do self screening. When should we start? Well, definitely at 30, and women living with HIV at 25. In South Africa, there's a guideline now. It used to say by the HPV board, it used to say 25. They've actually moved it up to 30, but between 25 and 30 is the gray area, and you can start. I think if somebody's asking you to do it, I would do it. I would start screening at 25 with HPV testing. I would not do HPV testing routinely for somebody lower than 25.
So,
Okay.
Celeste, that's because they'll all have it, is it? But also,
Yeah, well, 90% of them will have it. And then,
Yeah,
you know,
because-
then you need to have the conversation. They're worried. You start surveilling them. You might overtreat them, and they might still clear it within 2 years. Now they're stressed for 2 years. You have to check them. Really, 90% of them will have it, and up to 90% will clear it. So we're waiting to see who will be the 5 to 10% that's not clearing it, and then the further 5% or 10% that will then become a CIN lesion. Okay.
Okay.
This is just with regards to follow up what you should do. That's just minor details. So why should we do HPV testing and not cytology? Better sensitivity, better specificity. Okay, and sensitivity is the big one that we actually want to be high in this type of test. If you go back to your statistics and this means that you'll have a better positive predictive value, a better negative predictive value, better reproducibility. You can do the self-sampling with HPV. You don't need to swab the transformation zone. That's the best of it. So if I'm seeing it's a difficult pap smear, I say, you know what, it's okay. You know, I just do a swab sometimes of the cervical or the upper vaginal area. You know, you don't need the transformation zone right in there, which is great. And so they actually show now, yes.
On that self-sampling, people always ask us, you mentioned gay women. Oh, there you go, self-sampling. Now,
Yes.
sometimes I'm doing a pap and with the best intention in the world, I don't see the cervix. They might have an incredible voluminous, or the cervix might be some crazy place, or it might be too sore, whatever.
Yeah, exactly, yes.
So what do I do then? Do I use that little swabby? But the little
So
swabby.
you can use any they call it like a pus swab, dry pus swab, like in this picture, right? You can even use that, or you can just use your pap smear brush or your broom and just insert it into the vagina gently without a speculum, and then do a 360 turn. They say 30 seconds, and then you can put it into the liquid-based cytology thing, or you can just put it into this dry specimen. Some of the labs have their own pre-made self-screening sampling cannulas, or what do we call it? The actual swab with a container. But you can also just do this. And it detects, they have actually studied it. It detects the HPV equally. Patients like it more, especially in those scenarios that you've mentioned. It's got a high sensitivity. And we've seen now that if we do this, it reduces cervical cancer more, the incidence more than cytology. So really, I'm trying to convey the message that if you're doing cytology and cytology only as your primary screening test, you are missing more cancers than what you would have, potential cancers. Okay, we are reducing more cancers by doing HPV testing. So please help us by reducing cervical cancer by doing HPV testing instead of only cytology. I hope I've convinced.
Yeah. And just wondering, so we've been talking about self-sampling for quite a few years now,
Yeah.
and it's just very interesting that it's taking so long to get traction, because it's kind of a little bit of a no-brainer if it's performing exactly the same as a healthcare worker doing the sampling.
Yes, no, I agree with you. I think it should be something. So I think in the Netherlands they actually send it in the post, almost like the fecal occult blood test, or they do to screen for if their patients, older patients need colonoscopies. They also send these tests now in the post, and then you can swab yourself at home, put it back into the container. They give you all the instructions, and then you send it back in the post to their lab or whatever, and then they let you know with another letter. Okay, great. An email, this is your result, please come in, it's flagged, whatever. So yeah, hopefully one day we'll get there. I mean, of course, in our setting, it's very difficult in our country. The systems are all set up. So
The postal service. But also, Celeste, the thing is the cost. I mean, I won't mention the name of the laboratory. They've got a special little lacquer little swab. It costs 600 Rand. And that's why I was interested to when you said, you just use a normal swab and just off it goes. Because if you're going to have cost involved, which is considerably more than cytology, and HPV is more expensive, if
yes.
that could come down, and we're not going to do cytology, if it could be equivalent in cost, I think that would be a great
Yes. And remember that if you look at this, so actually you're also gonna, yes, the HPV testing is slightly more expensive, but if it's negative, you can, for some people, that's the patients that are HIV negative, you can repeat it, they say 5 to 10 yearly. Okay, in South Africa, the
10
guidelines
years.
now say in 10 years. So then you also save money in that way. So you can increase the frequency of surveillance. If you're going to use cytology, you have to do it every 3 years. In the women living with HIV, you definitely need to consider doing it 3 to 5 yearly, depending on the viral load, with their previous cervical screening history. But that's the one way of justifying the increased cost, is saying, listen, if I do it now, it's negative. I can see you in 5 years for another screening test. And some women, actually like that. They don't have to do a yearly HPV DNA screen.
Yeah.
Okay, so sometimes people ask, what about you? Also, there's a little tick box on the form. Should I test DNA? Should I test RNA? So you should test the DNA one. It's just better with sensitivity and specificity. So the RNA we use to see, you can use it for triaging, but it gets complex. So don't forget about the RNA. Don't worry about that. Just do the HPV DNA testing. It really just detects the presence of it. That's what we want to know. We want to know, is the HPV there or not. Okay, this you can help you to triage and long stories. I'm not going to go through all of this. Self-sampling we've spoken about. So yes, there are nice algorithms depending on where you are. This is HPV DNA testing. So they use it as a primary one. And yeah, they say if it's negative, you can rescreen with HPV in 5 to 10 years and women living with HIV in 3 to 5 years. If something's flagged, they don't subtype it here yet. Yes, you can do cytology, fine. And then, there are different pathways that you can follow. Here is one that also shows about the VIA triage. That's more in resource-restricted areas where you can teach the nursing staff to do the acetic acid, and if they see a flare or a whitening, then they'll follow the steps. But for us, really, I think this is really more, let's say, easier to follow. So they've actually changed this now. The HPV board and I think SASOG also has said all women 35 years or older definitely needs a primary HPV screening test every 5 to 10 years. If it's negative, here we go, 5 to 10 years, you can repeat it. Okay. If they are 16, 18 positive, so we are going to subtype then if they are positive. And then you should add 45. And if 45 is in that result, you can treat them directly. Okay, so if somebody that can't follow up, somebody definitely that's done with childbearing, you can consider this. Or if you can't see the transformation zone, that's also another important one. A woman that's 50 that has HPV 16 or let's say 60, and she's postmenopausal, you can't see anything on colposcopy. While you can, you've now done a colposcopy, you don't think you're going to see anything, you can treat directly, meaning you can go and do a LETS procedure, LETS sleep, because 15 to 20% of those patients has cancer already. So they think, microscopically, and 50% will have cancer in 3 to 5 years of those ones that have this already. So that's how they justify it. And then you can say, then they triage it into other high-risk groups. And here they've changed this. They've actually taken this out. This gets a bit complicated, but you'll do reflex cytology here. So you'll do HPV, you triage with cytology. And then if it's obviously high-grade lesion, you're going to treat, follow it up in 12 months. A locil or a CIN1 lesion is not considered a precancer, and you can just follow that up for the other high-risk ones in 12 months. And if it happens and it's persistent, then definitely you should do colposcopy or consider treatment directly. You're going to follow them up again in 12 months. A lot of times, and especially in the young women or the women that are requesting HPV screening, let's say they're 23, they have a positive HPV result, whatever it may be, and or let's say it's other high-risk groups, and they've got an ALSIL on their smear, and then they're very worried, and the clinician usually that refer them, they're usually very worried. So remember that an ALSIL, a low-grade lesion, shows up as a low-grade lesion because of the HPV's presence usually in the other high-risk types. So it looks different to the cytologist, and then they report it as a low-grade lesion. But it does not mean that there's a precancer. It just means that it's a marker of infection of HPV more than anything. It's something to watch. It's not something to ignore, but it shows up, and you need to make sure that there's nothing more going on. But you can then follow it up in 12 months.
Okay, so that is quite confusing for some of us because, you know, if we think that it starts as low cell and goes to high cell and then goes to cancer, you're saying here that low cell under certain circumstances is not pre-malignant because of the
Yes.
benefit
It's
of
it's more a sign of, so sometimes if they see that colocytic signs where, you know, that virus, what I showed you in the beginning, where the HPV actually goes into the cells, that looks to the cytologist as they'll report it as a low-grade squamous lesion, and that's sometimes just a marker of the actual HPV infection. It's not seen as necessarily as a precancer.
So how does the body clear that virus if it's not in the circulation, if it's just sitting in?
So you've got antibodies, and what happens is the antibodies also go. So we think you're getting HPV because of little breaks in your cervix, and you've got antibodies, circulating antibodies that also then go and lie there and sort of bind to the virus and deactivate the virus. And somebody that's vaccinated, they've got lots more antibodies that can go. You know, it's not cell mediated; it's antibody driven, and so they lie in those little cracks and then can sort of prevent the engulfing of the virus into the cells.
Right.
Okay. I'm not a virologist, just saying. I'm trying to explain it as best as I could.
Made it beautifully clear. Thank you.
So, what do they say then? For 90% of patients, we need to definitely treat them if they've had a positive screen. And treatment, they talk about this. I mean, ablation there are different rules that you need to follow if you really want to ablate. And these are really more for resource restricted areas. You can do it. There are a few rules that you need to follow. But whatever you do.
What ablation is that that's just taking your bipolar or your unipolar and doing
so you can so they actually now have introduced, you get a lot of these at the right top corner there, you get a lot of these handheld ablative instruments that actually does thermal ablation, as you can see there, and it ablates that whole area. But you have to be able to see the whole transformation zone. Your colposcopy needs to sort of agree with your cytology. There should be no weird high-grade lesion, and now you're thinking, okay, or glandular lesion. There are a few rules, and that's also a discussion for another day. But it is something that you can do, but you don't have histology with that, and really it's advised for more resource-restricted areas, I would say. If you've got the means, you want an excisional specimen so that you have the histology to prove that there's no microscopic invasion.
Now, what does CKC stand for?
Where?
In the middle, CKC?
Cold knife cone. These are the old historic ones. If you have the equipment in some areas in the world, the WHO says we can do like a cold knife excision. But I mean, the standard is let's leap, and that's completely acceptable, for us to do that.
And what does LEAP stand for?
That's an American term. I think it's loop excision. What's it? I'll tell you now. But it's used interchangeably. Let's, yeah. What I want to say here is that don't be too hard on yourself if you did do a good proper LETS and you see that some of your patients still have the HPV or high-grade lesion, in 6 months' time, because about 7% will fail treatment. And definitely, women living with HIV, about a fifth fails treatment. So that's not on you, okay? It's important.
So what would you do if you have your LETS, you've got your little histology, and they say that your lesion goes to the margin, the lower margin? what do you do then? Although you have ablated with your bipolar or your monopolar,
Yeah,
whatever.
afterwards, yes. So
Yeah.
it depends. I think it depends on the patient, the type of cytology that you've had before. If it's a nulliparous patient, that is 28 or 30, I would just wait for everything to heal, and I would repeat my cytology, my HPV testing, my code testing in 6 months to see test of cure. It's fine because, like you say, you do use your ball cautery afterwards, and you could have removed more of it. And if there's less HPV, maybe your own immunity then has a chance to then just clear that maybe SIN2 lesion that you have there. But if it shows something that's query microscopic invasion, then I'd definitely not just leave it. So it depends on the case.
Okay, thank you.
Special scenario, I've actually talked about this a little bit, but what about the young patient, nulliparous patient? What should we now do here? I said to you, more than 90% clear the virus, whatever it may be, even 16 within 2 years. And if it persists, that's the main risk factor for SIN3 and cancer. So we also want to preserve fertility. And the next question is always, how will this influence my fertility? So actually, falling pregnant, no, there's no way that will, having a LETS will influence that. But if you've had an excisional procedure, so a LETS, it does increase your risk for preterm birth, cervical insufficiency, and PPROM. That risk starts going up with deeper or repeat excisions, and that's from about 15 millimeters depth. Okay. So really, when you want to be conservative is when I said earlier, you have this HPV other positive with a ascus or a locale, and you've looked on the colposcopy or whatever algorithm you've followed or you've referred, and they say, look, it does just look like a low-grade lesion. Definitely surveil them. Don't do a LETS for them just because there's an ulcer and HPV other. So SIN1 lesion that you've proven with a biopsy, you're definitely going to observe, and you can then repeat it in 12 months. Okay. Selected CIN2, the argument here is some people say you can surveil them closely in compliant nulliparous patients. I would be very careful to do that. You really need to know what you're doing if you want to do that, because it is considered a precancerous lesion. Here, we're not just talking about, it's transient HPV infection like with a locale. But some places in the world or centers, they would consider this in very young patients. And of course, if it's a SIN3 biopsy-proven lesion, you do need to excise the lesion, even if they are 22, like your other patient that you said now. So what are the principles? The smallest effective excision. So when you do the LETS in theater or wherever you are, you need to do especially for these patients, a colposcopy and see where am I going to excise the lesion. I'm not going to just do a LETS without being a directed LETS. You don't want to just see and treat. So just because they're HPV 16 or 18 positive, you're not going to definitely immediately do a LETS for them. Definitely not. Try and minimize that cone depth of excision that you have and avoid repeated procedures. And then here, once again, vaccination is very important for these patients. Protects against the additional HPV types and reduces, I said to you, we have evidence, recurrence into after you've treated them now with your LETS. This is just a table to show how the absolute preterm birth risk goes up once you've cut, more and more of the cervix off. So really, the baseline for any woman is 7% more or less for preterm birth. So if you punch biopsy, there's no issue. Less than 10 millimeters, really nothing. And only a little increase here when you go from 10 to 15, but from 15 millimeters upward, you can see the relative risk goes up quite twofold and 2.4-fold. Last few words on will this work? Hopefully, Australia has proven it. They've actually, since 1991, introduced the screening program, and nationally in 2007 for boys and girls. And they've not only done it through schools, they've also done it actively through their GPs. They've got this Aboriginal medical services and workplaces. And we actually see that they've halved the incidence and decreased the mortality of cervical cancer by a third. So where there were 13 cases per 100 and deaths 2.7, they're at 1 to, I think 20, they're hoping that to be even lower now in 2026. And by 2066, I think they won't see it anymore, cervical cancer. So
Yeah, I
it's
read
worth.
that recently in Australia. In this
Yes.
last year, they haven't had any new cases. So it's certainly
Yes, exactly.
Sure.
Yeah. So we can prevent it. And just as a reminder, so try and vaccinate 90% of the young women or women that you see. 70% needs to be screened. We need to screen everybody. Don't start before 25. You can start from 25, definitely at 30. Use HPV, please. If you want to add cells, add the cells. It's more money, but it's okay. But at least just do the HPV. And then, 90% of women have a system in place where you can trace your abnormal results. And I have a separate Excel sheet with all my results, and I can trace those that I can't, I see I've informed them they need a LETS or they need something more, and they're not coming back to me. I try and contact them again. I have some sort of system to try and implement that I can treat 90% of the ones that I've picked up. Okay. And that's it.
a wonderful talk. Thank
Yeah.
you very much indeed. Before Steve thanks you, Celeste, there's one or two questions. Steve, do you
Sure.
want to run through them?
Yeah, so Marcus has come in another question. Marcus Fassin, the WHO target for 2030 is 70% uptake of cervical screening. And what is the cervical screening coverage percentage at the moment in South Africa? With only 5 years to go till 2030. Do we know?
Sure, I actually have to go look. We're not there.
Not
We
yet.
close. I mean, it depends on where you are. Rural areas, very low, 10, 20, 30%. More metropolitan areas, it would be higher. It really depends. I don't know what the average is. I'll have to go and look, but we're definitely not close.
Thank you. Next question, Steve.
Yeah, so Rochelle Majola would like to know, what does it mean when the patient has LG-SIL?
What's
But
LG-SIL?
Yeah, but the HPV
It
comes
probably
back.
means low grade.
Oh, low grade.
Yeah,
Oh.
the HPV comes back negative, and negative for all HPV strains.
Yes, so sometimes, yes, that's a very good question. So I'm not worried about that. A low grade lesion, if it's not glandular, so I hope he or she doesn't mean, I didn't hear the name now, glandular, because there's a difference between atypical glandular cells. There, you need to be very careful. You need to investigate. You're gonna do your, but if she means low grade lesion, and the HPV is all negative, even, the subtypes, everything's negative. It's probably either thrush, or candida, even bacterial vaginosis and STI, anything that changes things around there can give you the impression of a low-grade lesion.
So then brings another question. I mean, do you actually do cytology, or do you only do HPV then? Because I mean, it then just brings in the confusion. And what value does it add? And do you actually have this conversation with patients about adding cytology?
I do. So I mean, what I do and what I say you should do is probably two different things. I do HPV primary testing. Reflex cytology is the next thing I do. Patients do want cells. Sometimes the cells help me and I do it together, but really you don't have to. It is more money, and I'm not saying you're wasting money, but it's not necessary. If you have a system in place, on the form, and some of the lab forms do say, primary testing, reflex cytology, then that's what the WHO says you should do. So if it's positive for primary HPV testing, you genotype it, or you use cytology, and it can help you. You can avoid unnecessary biopsies. Let's say if a patient doesn't have the money to pay in private for a biopsy, but a lot of times you just want that flag, and it depends on the patient that's sitting in front of you. We can always follow protocols. Lots of my mentors also always taught me this. And the big HPV people in the world is, yes, we have the protocols in place for the general population. But of course, if somebody is sitting in front of you, what do? We individualize. So it depends on a lot of things, and I decide as I go on. But I definitely do HPV testing for everyone that I screen.
Do you do HPV testing and pap smears for women that are pregnant or not?
I don't really see pregnant women any longer.
But
because
I do. Should I or shouldn't I?
Well, you can, yes. If the question is, what do you want to do with it and what can you do with it? It's good.
That's
It's an
the point.
opportunity to screen, yes. You can definitely do colposcopy and biopsies in pregnancy. If you're worried about microinvasion and if HPV 16 is there, you can do that. That's acceptable, you know. It depends on the patient, the age of the patient, and have they been screened in the last year. Then I wouldn't repeat it if they've had a screen in even the last 3 years, because if the cytology was normal and you've done HPV testing before, you have 5 to 10 years. So just try and figure out if they've had a test recently. You probably don't need to, you know, but it is a good opportunity to use to screen them, and that's why we should use to, you know, we need to think of it.
All right. There's a patient there's an anonymous person that says a patient with that who's positive for HPV 16 or 18 in pregnancy, first trimester, RVD reactive as HIV positive,
Yes.
reflex cytology says local. How would you advise management for this woman?
She must get colposcopy. If there's
Okay.
HPV 16, 18, or 45, she must be referred for colposcopy. Okay.
Next
I've had a lot of HPV 16 with normal cytology, and then when I do a colposcopy, they've got a SIN2 or SIN3 lesion if you do a biopsy at the right place. So it can happen. That's why cytology is not the way to go for these patients.
And then Pierre Monji is asked, why a patient who's older than 40 but HIV negative are treated, while those less than 40
Yes.
HIV positive are not treated immediately?
Yeah, so they've actually changed that. It's just because above 40, if you're not clearing the virus and we're picking up the virus, you really should be clearing it. And we were a bit more worried about it. But they've actually changed that 40 and HIV status in that South African algorithm to just doing reflex cytology and going on that. So yeah, don't worry about that.
Marcus is back again. Could it be considered to include HPV vaccination for boys as well as girls in the childhood vaccination program?
Yes, we wish they would. Yes, they should.
At what age would you start? You said it's safe from 6, but when do you, as an oncologist, say we should start screening?
Start vaccinating.
Huh? Start vaccinating.
So the pharmaceutical companies, I think, would say from 9, and that's what we do. And usually what the private clinics sometimes what they do is when they go for their 12 Tdap, the tetanus, diphthery, that one, they have one at 6 and at 12. And that's where you want to do it then. If they're not, you know, in the program where they're in grade 4 and 9 years old, then take them at 12 and that same vaccination on the same day. Then you don't have to do a separate visit. But yeah, definitely any time, even if they come to me and they're 16, vaccinated. The question is at the top of my head, are you vaccinated? Can we vaccinate you?
All right, it's good.
Steve, next question.
Yeah, another anonymous attendee. Would you do HPV or cytology or both as screening on a 20 to 25-year-old sex worker? Individualize and not wait until she turns 30, as HPV is likely to be positive in this age group?
Yes, that's a very good question. I think, well, yeah, she's at high risk, and we don't know what age she started having intercourse. And so, yes, I might consider doing HPV testing, and it might be positive, but there your cytology can help you, your subtyping will help you, and definitely using colposcopy if it's in the means or in the privately or wherever you can when applicable. Because the argument is always you screen somebody now and tomorrow they can go and get HPV 16. It's really the duration. So if they've been a sex worker for a long time, you want to know if they still have some presence of HPV, which types they have, and you want to surveil them closely. So yes, I would. Definitely at 25.
So that's just before Steve. Unfortunately, we run out of time. There's so many questions still remaining.
There's one last quick one, which I think is relevant. Is there age cutoff for vaccination? The answer is no. Or
No.
what is?
No, it's less likely to have a great effect. They say from 45, it's less likely to really make a big difference. But if you're doing a LETS at 50, yes, I would still do it. There might be a small benefit. We're not going to know how much, but there might be. And if the patient can afford it, then for sure.
Okay, thank you.
I'm surprised, Steve, that the local South African laboratories don't provide better facilities for self-screening. In other words, we all got the little cyto brushes, we all got the little bottles that we send the stuff off with. But every single laboratory should give you a little kit for cell screening.
I agree
There
with
is one lab
that's
that does
true.
it, but it's 600 Rand. I mean, I don't know anybody that's going to take it up. But if Celeste tells us, no, you could just get your normal swab and swab away. I'm surprised that this hasn't been a sales pitch for them. And I think that Celeste should maybe have a word with them and say, this is
Maybe.
what we can do. Celeste takes 5%, and then the rest of us send a thing.
Yeah, that's right.
Imagine.
I think it's a completely lost opportunity.
Yeah.
It's been
Yes.
discussed since I was a registrar, which is many years ago, and we still didn't do it properly.
Yeah.
And I think it'll make a big difference to patients, which
I
is
think
what we
so.
want. So, yeah, I think we've come to the end, Pete. It's been wonderful, Celeste. You've really demystified it for a lot of us. I think we've got very clear guidelines. I
Good.
think the answer is that we should offer everyone HPV as a test.
I'm still scared of pregnant women, though, Steve. As
Yeah,
Celeste says, if they've been screened 3 years before, that's great. But
Yeah.
us
No, that's
people have never been screened before,
Yeah, but
because most pregnancies, and in my
and
practice,
then
are
vaccinate.
unplanned.
Yeah, but then vaccinate if they haven't been vaccinated. And
But you can't vaccinate in pregnancy.
we're not talking about pregnancy.
Oh, you're not. Okay.
we're doing, yeah, but screening, yes.
No,
Yeah, maybe one day you can, in the very near future, give us another talk. Would you be prepared to give us another
Yes,
talk?
yes.
Regardless,
I said to, I think, who was it? Chris before you guys
Christopher.
came. Christopher, yes.
Christopher.
Yes, I said, yeah, definitely. If you would want me, yes, for sure.
That's
Yeah, no, I
fantastic.
think
That's
there's
wonderful.
a lot still to talk about on these things. I think the algorithms can be still a bit confusing for us, so that might be quite a nice way
But
to.
not only cancer,
Yeah,
cervix, Steve.
yeah,
What about
yeah.
other things? I mean, there's
Yeah,
lots of it
yeah.
floating around.
Anyway, thanks so much. I think it is time to go. It's getting dark here in Cape Town now. So,
Thank you, everyone.
and thanks so much. It was wonderful. We know it takes time to prepare these talks and to, be here with us, but we really do appreciate it.
And it's
And
voluntary.
yeah,
Thanks so much for
thanks very much.
not.
Yeah. And thanks to Songezo as well for and Aspen for their sponsorship, and thanks again to Chris as well, and thanks to Pete. Very much
Thank you,
appreciated.
everyone.
Safe
Bye.
home, everybody.
Thanks,
Thank you very much.
everybody.
Thanks.
Thanks.
Bye.
All the
All
very
right.
best.
Cheers. Have a
Thanks
good
very much,
evening.
Songeza.
Bye.
You're very much welcome, Dr. De Jong and Prof.
Thank you.
Thanks,
Okay.
Songezo. Bye.
All right, thanks. Bye.